Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for the second season of conversations aiming to bridge gaps surrounding dysphagia intervention. Swallow the Gap podcast is a production of Gap Education, and we are predicated on a mission to improve dysphagia care. Nothing we say is legal advice, nothing should be taken without scrutiny. While we strive for accuracy, we do not imply perfection. We value diversity in backgrounds and opinions, therefore our guests will not always reflect what we believe. In fact, we may change our minds as we learn more because this is how progress is made. Through critical reasoning with open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Welcome, everybody. Joining me today is Dr. Gabriela Constantinescu. She works with the Ministry of Advanced Education with the provincial government in Alberta, Canada. She has a background as a clinician for about a decade and has a PhD in rehab medicine. Dr. Gabriela, let's go with Gabi today, right? As I understand, that's what you prefer?
Yeah. Hi, Tim. Thanks for having me.
Yeah, no, it's glad to have you with us. Thanks for being so quick on the turnaround time. That was excellent. What else would you like for people to know about you before we get started?
I guess I always like to point out that I'm from Canada. So, for any little shout out to any fellow Canadian listeners. And yeah, other than that, anything that you want me to chat about is fair game. So,
Okay.
happy to be.
Yeah, sounds good. Glad to have you. For a little bit of background, I reached out to Gabi when I was looking for somebody to lecture on sEMG, surface electromyography biofeedback. I came across an article, post in the ASHA Wire, I think in 2023. And so you so graciously agreed to provide some education on that. And that'll be coming up at Rocky Mountain University's Hard to Swallow Catalyst for Change in Dysphagia Management Conference. But this today is a standalone. If people are listening to this after the conference, that's fine. I would certainly point you to that article in the ASHA Wire, but we'll get some more resources later too. So anyway, thanks for all of that. Really, truly appreciate it. Would you mind, just in a very elementary way, describing to us what sEMG is and what it's typically used for swallowing?
Yeah, absolutely. So sEMG stands for surface electromyography, and the surface bit is an important distinguisher because there's also needle EMG, and they don't use a little n, they just say EMG. So surface electromyography is essentially a way to look at the extent of muscle excitation. So a simple way of saying that is looking at how hard your muscles are working and for how long during an activity. And in our field, I've seen it most successfully used with teaching certain exercises because, like you mentioned at the beginning, Tim, it's hard to conceptualize what we're doing with our swallows, and even our own exercises. Swallow hard. What does that mean? Swallow and at the top of your swallow hold. What does that mean? And it's even harder for our patients to understand that. And then I've also seen it be used to elicit effort. So I see you putting in good effort, try to beat that, try to get that peak a little higher than the last one, as well as increase self-efficacy in patients. So what that means is that confidence in the task, I'm doing the task correctly, and I want to continue doing this because I'm engaged with it and I see progress.
All right. With some of with a recent podcast recorded on respiratory muscle strength training, we were talking about the difference between skill-based training and strength-based training, right? And so, I mean, if we're doing something that is predicated on transference, like we're doing, let's see, the Shakir, or we're doing respiratory muscle strength training, we're working specific muscles in non-swallowing activities, and we're hoping that will somehow have a transferable benefit to swallowing, then, those are, but a lot of those are strength-based exercises, right? And so this really seems to exemplify one of the true skill-based exercises. I mean, it's working on strength, of course, too. But I think that it seems to be a lot more potential for skill-based rehabilitation within this. Would you agree? Or you think I'm off?
No, and I think they all, at least with the patient population that I was working with, these are patients with a history of head and neck cancer. I would say they all kind of go hand in hand. I remember during my PhD sitting down with a mentor of mine, and we were trying to hash out, okay, well, what are we actually working on here? Is it like you mentioned, is it strength? Is it endurance? Is it skill? And after a very good conversation, we settled on, I think it's all three ultimately. So, for instance, with surface electromyography, if you were sitting down in the clinic with a patient and it's your first session and you were walking them through, this is what a regular swallow looks like on the screen. This is what an effortful swallow might look like. This is what a Mendelssohn swallowing exercise might look like for this particular sEMG technology. Then at that point in time, you're working, of course, on the skill part of it. But as you progress throughout your treatment block, maybe you are now working on strengthening because you're, let's say, 6 weeks in and the patient has done this daily and now they're working on that hypertrophy we're all aiming to get. And then after that, maybe you're even increasing the number of repetitions in a session because your patient's reporting that this is starting to be easy. So now you're potentially working on endurance as well. So all of this plays into the type of muscle fibers that are being targeted by the exercise and how you structure your exercise regimen.
The fast twitch and the slow twitch and
Yeah.
yeah, no, that's fantastic. I appreciate the insight that you can bring into that. I guess I'm thinking like relative to some of the other things we do, there's a lot more skill involved, which I think is great because in terms of neuroplasticity, we're getting some more specificity, which may help to improve our outcomes overall. If you
Thank
don't mind,
you.
tell us a little bit about how you got into SEMG.
Yeah, for sure. Don't mind at all. I was actually just very lucky. I was working in a clinic here in Canada that actually could afford to purchase the surface electromyography equipment that I was introduced to. So at the time in the clinic, we were using the K-Pentax surface electromyography. I believe it was the Swallowing Signals Lab. And I remember one of my colleagues training me on it and telling me how to set up for patients and how to use it. But of course, it wasn't something that I had learned in school or been exposed to. So it was a bit of a learning curve. And it's been ever since. So I can empathize with anybody kind of starting fresh and seeing it for the first time and wondering what it is and what it does and what it doesn't do. But I've also come to really love it now that I understand it a bit more, not fully, not like a biomedical engineer, but a bit more than I did when I started out.
Yeah, I kind of notice a pattern with these episodes that you mentioned you didn't have a lot of exposure to this in graduate school. So you got out and it was kind of a new thing. And it seems like there are so many of those things just because,
Mhm.
even just learning about the normal and disordered aerodigestive system for swallowing, we don't get so much of that. So to squeeze in all these treatments, especially treatment methods that are less ubiquitous within clinics around the world, there's it seems like there's a steep learning curve with that. And so, I mean, just so much of what we do is initiated by our own drive and we have to be motivated to do this on our own. So that pattern is there. But SEMG
Yeah.
is not something that I have personally worked with in the past. I know some about it, of course, and I've seen it at conventions and I have the idea of the utility and whatnot. But so when you were working with this, or when you started working with this, what do you think struck you as something that gave it an advantage versus your traditional therapy with effortful swallows and Mendelssohn's and that type of thing?
That's a, that's actually a great question. I saw, I, I mean, the simplest way to put it is I saw a little sparkle in my patient's eyes. I saw them engaged. So when they were looking at the screen, they were focused more on the effort that they were expending during that exercise. And they were focused on ensuring they were doing the exercise correctly. And they're almost like trying to beat their last score, if you will, versus when we weren't using it and it was this face to face sitting across from one another. And I don't, the best way that I could describe it was kind of an awkward moment. Like, okay, swallow hard. I think you did, and
Yeah, right.
try again. And you're just sitting there, clipboard. So yeah, so that would be it for me. Its biggest advantage. But at the time, I wasn't really able to articulate it beyond that. It was really when I started my PhD that I understood why that was happening. And that's because, and this was, not my words, but I've come to read from others that surface electromyography, or really any type of biofeedback that gives us this information about what our body is doing that we can't readily see, essentially reward small increments towards that progress that we're all aiming to get to. So for my patient, it was, if they were coming in with this notion that by the end of our treatment block, they were going to be able to have a burger at a restaurant after, or something like of that nature. Seeing progress via sEMG and biofeedback to them was a reward that kept them going, kept them showing up to therapy. And it wasn't this, well, I don't even know if it's doing anything, so I'm just going to give up because it's hard to come into this clinic anyhow. So yeah, that in a nutshell, I think biofeedback and sEMG in particular are quite remarkable in that sense.
Yeah, there are several things going through my mind when you say that. So you talked about sitting across from the table, watching someone try to do an effortful swallow and being like, oh, I think you did it. I mean, how many of us can relate to that? You're watching, okay, the larynx bob, they look like they're really squeezing and squeezing hard, that type of thing. But there's no real empirical measurement to say,
Mhm.
oh yeah, that's what is occurring. They're doing it with more force than they would just do a typical swallow or something like that. But also the
Right.
idea of how we do so many things that are skill based, whether it's some sport, kicking a soccer ball, throwing a football or a baseball, something like that. We have this sensory motor integration system going on. We have proprioception. We feel where our arm is as it's, kind of at a 90-degree angle to our side or behind us as we get ready to throw something. And we adjust and course correct. I mean, we have this plan, like I'm going to throw this ball, I grab it, and I'm going to move my hand forward and release. But also during all of that, you got proprioception. And so we can make tiny modifications as we go. And so as I'm thinking of swallowing, like swallowing is a black box to so many people. It's a mystery. I don't know what's going on within there, 30 some muscles and however many cranial nerves you want to go motorically for about 5. But then you've got the sensory input from olfaction that makes you salivate, and like so many things. So you have that. But anyway, it's such an unknown. But they can see like a visual representation of what's going on, so that they can help to change that or do something, to change that or do something differently. The same thing, I guess, is what I'm saying, but you can modify it, right?
For sure. Yeah. And I mean, a relatable example for all of us is, well, maybe not me recently, but when we go to the gym, you're on a spin bike, for instance, and you see that number go up as you're giving more effort. And that makes you want to put in more effort and see if you can get that number higher, right? Like we all have this tiny little competitive spirit inside of us that I think is what sEMG biofeedback capitalizes on when you have patients using it in therapy. So yeah.
That makes a lot of sense too. For anyone who has tried to lose weight or has tried to gain muscle mass, it goes sometimes so slow that you don't see it happening. But if you get on, if you don't step on a scale for a month and then you come back and it's like, oh, I'm 10 pounds lighter, that's awesome. Or you see a picture of yourself 3 months ago, you're like, well, that's a big difference. You have some empirical evidence of that things have changed. And I think that's such a motivating driving factor. And I mean, even the gamification with this sort of thing, like making rehab fun to be able to gamify SEMG as as part of our therapeutic regimen. That's super cool. And so you were a clinician for about 10 years, and then you went and got a PhD in rehab medicine.
Mm.
And as I understand it, you focused much of your PhD on SEMG. Is that correct?
I did, yeah. So I think at the beginning I was a bit, if I'm fully honest, I was a bit averse to it because I didn't know what my relationship to SCMG was. I didn't know if I really liked it. But my PhD supervisor pushed me to, this is something we're gonna go down, and so I started loving it after I understood it more. I was more admittedly drawn towards the gamification side of things and making therapy fun, like you had just said. But yes, I did spend 5, almost 6 years getting very intimate, I would say, with the technology. And again, I think it's by virtue of all the opportunities and good people that I was so fortunate to have around me, like biomedical engineers who became my friends. Initially they were kind of in teasing me for not using the technology appropriately, and then
Mhm.
I learned to gain their respect. And then going to them and appealing to them whenever I didn't understand something, or just making sure that I was explaining something properly to myself and to others. And that's also been a really, really benefit and a good opportunity for me while I was doing my PhD.
That's really cool. There's been another theme as I've recorded some of these most recent episodes that deal with treatments that are non-traditional or at least not super widely adopted. The theme that I see is there's more interdisciplinary work that's included within this. So you're talking about working with biomedical engineers, and that makes
Mhm.
sense because it's technology. But one was with Dr. Bendix Labite, and that had to do with um, collaborating with physicians. And so I think this is potential that we miss out on, that there's
Mhm.
so much that's right to tap into when we consider the things that other people know. I mean, people have studied physics for years, or people have
Mhm.
studied biochemistry and can understand on a microscopic level, or on a level relative to the laws of physics how things work. Because, we have a lot of training. We have training in the body, we have training in language and in speech and all these different things. But there's not, I mean, not only perhaps is, in my opinion, our training typically not sufficient for us to do what we need to do, but there's so much more potential when we tap into the expertise of those around us. So I just think this is another exemplification of that. I think it's great. That's
Sure.
that's super cool. I wish I could work with some biomedical engineers.
I know they're my favorite crowd, and designers. But you tapped into something that I'm really, really passionate about, and I've only become passionate about it again because of the experiences that I've had. So, for example, in clinic, I had the good fortune of working alongside biomedical engineers, designers, anaplastologists at the time. And what that did for me is it helped me understand that I can see my clinical, I'll call them problems, my clinical challenges, problems from a very different point of view, which in school, again, not that I've had a terrible experience either. I had a great experience in school, but we weren't taught that interdisciplinary interactions could mean disciplines outside of the healthcare field. So when we had our interdisciplinary classes, these were primarily with other healthcare fields. Had your PT, your nurses, your student physicians, etc., and you kind of went through a case study together and that sort of thing. But you never really were taught, even exposed to the idea that you could look at a clinical problem with the help of a biomedical engineer or a technologist or a designer who would potentially turn that challenge or problem on its head and give you something completely outside of your realm of imagination, right? So that has been just a wonderful, wonderful experience. And then later on in my PhD, what one of my committee members recommended is that I take this class where one allied health student was paired up with a couple of industrial design students and a comp sci student, as well as I believe engineering. I can't remember now very well, but anyhow, what we had to do for that course is come up with a clinical problem, which I had many of, having been a clinician for a while, and work together with these other students to come up with a solution. And you didn't have to, have a physical solution by the end of that course, but you could have a render or something that you could pitch or take from that stage on to a grant application or something that, was a little bit more than just talking about it in someone's imagination or creative imagination. So those two experiences for me have been just absolutely amazing. And I've seen too some universities now that I'm in this space. I'm sure in the States there are plenty that do this already, but some universities will also add a business component to what I just described, so that potentially by the end of that course, you would even have a business model on top of your innovation.
Very interesting. So a lot of different ways, a lot of different directions to take that potentially.
Hmm.
So, Gabby, I'd like to circle back around to something that you had mentioned earlier. You discussed doing interdisciplinary activities, even with individuals who are outside of healthcare professions, not just, people who aren't speech pathologists, but people who might not be working directly with patients, like engineers. And so it seems like there are a couple of things going on here that we could really move forward with. There is the idea of sEMG as one particular modality of treatment and the benefits of it. But there's also this idea of these new ideas that sometimes come up in university settings, but aren't as accessible for clinicians everywhere, or maybe aren't as adopted as early by clinicians in different areas who are outside of a university or maybe even a university medical center or something like that. What do you think are some of the barriers to that? And what are some of the ways that we can facilitate trying new things to see if this is worth adopting, whatever the technology may be?
Oh, what a great question. And my brain went into a million directions. So I'm going to try and focus my thoughts. It's an exciting topic. I think it, there are a few challenges, but what that really means is there are a few opportunities as well. First and foremost, it's tricky to get this new technology into post-secondaries so that students have exposure to it. Again, we were quite lucky in our university. We had exposure to the nasometer and at the time Percy SARS, and I think we even had the IOP. So we had some exposure to these technologies and labs set around them. So we got to play around with these. But I think what was missing for me in that setting was understanding how I could do with this technology if I was left to my own devices. So what I'm trying to get at is we had labs that were set up, and we, as students, we get busy and you're just trying to fill in the numbers that you're being asked to in the lab, but you don't really stop to think about, well, okay, but why am I being asked this? And how can I really apply this information 2-3 years down the road when I actually have a patient in front of me and this technology? So that was a challenge. And also when I did go back into teaching, how to impart that on students and how to get them to go to a manual, for instance, for a technology and learn to look at a manual and learn to ask the right questions and how do you work with industry and get what you want out of them. So that's one piece. The other piece is I think just getting excited about new ideas and getting exposed to what it takes to get new ideas. I remember just giving presentations again many years ago on the concept of what we were trying to do. at the time with mobility. But, just starting out, full disclosure, as a student, I also didn't know what it took to get a concept from, this would be a great idea one day, to this is something that is now out there. And so when students in the audience would ask about it, I didn't know what to answer. So I guess to get back to your question, I think exposure to that process is also important in the post-secondary world, just so that our future clinicians understand what it takes to have that technology that is in front of them arrive in front of them. And how do you inspire earlier adopters and folks who are, willing to take something home and play around with it and see what it does and try to break it and just really get curious about new tech? How do you do that? That's a great question. I think there are lots of people out there trying to understand how do you do that? And certainly my role here now with the government, we're trying to write policy and strategy on how do you incentivize and expose students to more entrepreneurial thinking and try to inspire a more entrepreneurial culture and a culture for innovation within the post-secondary setting.
So trying to encourage big ideas, getting people to go out and, sorry to be cliche, but shoot for the stars, more or less.
Yeah, yeah. And you never know where those will come from, right?
Yeah.
They come from your patients. They might come from students. They might come from just for us, it's good conversation over coffee and a croissant. So you just don't know where they'll come from. But yeah, there are lots of great ideas out there. It's also the understanding the process and what it takes to get from an idea to an actual materialized product or technology that's sitting in front of you. Yeah.
Yeah, and there is so much to that I don't understand. I've had a couple ideas, and maybe if you have time, we can chat about those a little later. But I just don't even know where to start to get things rolling. I've talked to people about them, so I think there's a lot in that. One thing I want to, it's a brief tangent, but it really weaves into this well. So many of us have ideas when we're in the clinic. We're doing something, or we get a different type of patient. Just something is unique, or something falls into place and makes sense, or we come up with a clinical question or a research question. I, in the past, have so much tended to overly rely on my ability to remember these things. And so just as a tool, something, not to say I do an awesome job at this or anything like that, but something that's worked so well for me is to just write those things down in a place where where you can access them. I've done it so clunky, in such a clunky way as to just email myself, and the subject line is idea. And so I can go back and look up emails from myself with the subject line idea if I ever want to sort through those and then filter through them a bit more. I mean, we're inundated with information. We're constantly getting, I don't know, more information about this and that and whatever. We're scrolling through our phones and watching reels and all sorts of different things. But also taking the time just to sit and to allow ourselves to process that we've learned too. I feel like that's where the sparks really fly and we make connections and integrate these things. And so those are two things that I would just encourage people to take away as well, is to, one, take time to process, just to not have input, and to talk about these things with other people, and then write them down. Like, have a place where you're not going to lose them, because our memory is not as good as we think it is. Or at least if anyone's like me.
Mine isn't either. And one of the things that a good biomedical engineer friend of mine would say is, don't get too protective about your ideas. Ideas come and go, and there's so many of them out there. It's really what it takes to get them out and materialize them again that is the hard part. So sharing your ideas with others and talking about them, you should be doing. Yeah, of course.
Yeah, I guess, and not be so afraid that, hey, this person's going to steal my idea. And that's
Yeah, exactly. Yeah,
yeah,
yeah.
no, that makes a lot of sense. That makes a lot of sense to me. Well, as we wrap up, I'd just like to give you the opportunity to throw some advice out there, or some sort of wisdom. What would you like to leave listeners with? It can be in addition to, or it can just be restating something that you've already mentioned that you think is very important.
Well, thanks, first of all, for this opportunity. And I guess if I were to go back and be a clinician all over again, one of the things that I wish I could do more of back then is just play with things around you, and especially technology. As I was mentioning to you earlier, Tim, I've had the good fortune of coming across some really incredible clinicians, passionate clinicians. And, of course, you're like, oh, I wish I was more like that. And how do we get more folks like that out there who are willing to figure out what's the latest and greatest, and then take it home and play with it. I remember we had one clinician who was like, yeah, I got my husband to use this, and then we played around with it and then made fun of it a little bit. So that to me is just that curiosity and love for learning and trying to figure stuff out that I would love to see in our field, in our profession, a bit more of. So don't be afraid to play with tech and get curious about it.
Great advice. Well, thank you so much, everybody. Again, Dr. Gabriela Constantinescu out of Alberta, Canada. If you have any questions, please feel free to email me and I can pass them along. I hate to like to put Gabi or people on the spot to be like, what's your email address? Will you please give it to the entire world? But there is always a way to get in contact with these individuals. You can reach out to me at tim@swallowthegap.com and let me know what you'd like me to pass along. And maybe there'll be another opportunity to follow up later. So again, thanks again. It was a pleasure having you, and we will hopefully see you all next week or the next episode that comes up. And reach out if you got questions or anything like that. And I think I'm going to quit talking now. Have a great day, everybody. What's up? Oh, wow. Oh, I'm rambling, totally rambling. That'll wrap up another episode. A big thank you to Dr. Gabriela Constantinescu for her insights on sEMG. If you have questions, feel free to reach out through email to tim@swallowthegap.com. Don't miss our upcoming fees course in Salt Lake City, Utah. It's a beautiful time of the year. There are direct flights from all over the United States and beyond, and we're currently running $100 off in addition to the early bird rate. Go to swallowthegap.com/fees100off. We're also running a $150 clinical fellow discount. Please email me for information on that. And before you go, one more course coming up. It is transitioning from fear-based to evidence-based practice in the Fluoro Suite with Dr. James Coyle and Joe Puntiel. Check that out under live courses at swallowthegap.com. Thank you so much, and we will see you next time.